Hello, PsychU community. My name is Brian Archuleta, and I'm a medical science liaison for Otsuka Pharmaceutical Development and Commercialization, Inc. I'd like to welcome you to today's interview for our Mental Health Across the Lifespan series with Dr. John Budin, one of our PsychU Stigma section advisors. Thank you, Dr. Budin, for joining us today.
It's really my pleasure to be here. Thank you for having me.
Thanks so much. This presentation is sponsored by Otsuka in Lumbeck, and our speaker is a paid consultant for Otsuka Pharmaceutical and Commercialization, Inc. So Dr. Budin, we are so excited to have you join us today. Before we get started on our actual interview questions, I'd like to give you the opportunity to introduce yourself to the audience and give us a brief description of your experience.
Sure, it's my pleasure to do so, and thanks so much again for having me here. I am a board-certified psychiatrist, and I retired about a year ago after 30 years of clinical practice. I've held a number of directorship jobs in hospital-based program and had a private practice for 30 to 35 years, where I saw everyone from adolescents to the elderly. I'm currently serving on the board of directors of the DBSA, the Depression and Bipolar Support Alliance, and I am the PsychU Stigma section advisor. It's a pleasure to be here.
Okay, thank you so much. Yes, we're really excited. I think we're going to get some great content today for our audience, and you have such a unique experience here that I think this is going to be really great. So again, this focuses on mental health across the lifespan, and as you are working with us in our stigma section, I thought we would start there. And so the first question I had for you is, in your experience, as a practicing psychiatrist, how does stigma associated with mental health impact individuals across various times of their lifespan? And do you see, or did you see or notice any differences perhaps in mental health stigma, maybe in younger populations versus adults or older adults?
Sure, those are great questions. I think in order to understand stigma across the lifespan, we have to take a step back and understand what developmental milestones and tasks we're tasked with over the course of our lifespan. So for example, if we think of adolescence, we can understand and remember as best we can, what it was like to go through puberty. And those are the crucial years when we're forming our identity and navigating our way through independence. And when we think about young adulthood or middle adult years, the tasks that we've got in front of us are, if we choose to, finding a partner, if we choose to, having a family, parenting. And these are the years that we have a vocation. We find our vocation, and these are our productive working years, for many people. And then when we think of older adulthood, again, the tasks that we have are things like approaching retirement, issues of parenting our own parents, health issues that come along for us, losing a spouse, and, issues around death and dying. So if we can understand the various tasks and developmental milestones, that's how we can best understand stigma across the lifespan. For example, if we think about adolescence, as you mentioned, most psychiatric disorders have their onset in adolescence or young adulthood. And mental health issues can have a profound effect given the crucial aspects of identity formation during these earlier years. And adolescents, particularly, the most common diagnoses like anxiety and depression, they can very much be on the receiving end of a lot of stigma during those years. They can receive stigmatizing attitudes from their peers, from family members, and as well, from teachers. So adolescents are judged and excluded. They experience dating rejection and a whole host of other things. They're teased and they're bullied. So, we can understand stigma during the adolescent period if we understand, again, the tasks and the developmental milestones that adolescents go through. Unfortunately, all of this results for young adults and for adolescents in loss of self-esteem and lack of confidence. So when we move forward a little bit into middle adulthood, all we need to do is look at parenting, for an example, and childbirth. Let's think of a woman who has postpartum depression, for example, and how stigmatizing attitudes come into play for such a woman. Oftentimes, women who are going through postpartum depression are viewed as being bad mothers, that they need to just snap out of it, like this is the happiest time in their life. Why are they feeling this way? As I said, these are our years when we focus on our job, our employment, and our vocation. And the data is really very clear that most employees will not reveal their mental health condition to their colleagues for fear of stigmatizing attitudes. And these fears are not unreasonable. They are not just fantasies in people's minds. There are real life repercussions when people have to explain gaps in their CV. There are realities that have to do with loss of employment or being passed over for promotion. So we can see how stigma, again, plays out based upon the tasks that people are going through. And in older adults, they face discrimination merely when accessing mental health care. Older adults, and this is my experience and my practice over the years, older adults can really struggle with getting mental health services because they believe that a lot of times, unlike I think younger people, they believe that mental health conditions are more likely to be the result of a personal weakness than a medical condition. And a lot of times older adults feel that mental health conditions bring shame into the family. So these are just some examples of how stigma can get played out across a spectrum of one's life.
Great. Yeah, that's fantastic information. Kind of to piggyback on that here a little bit, when you were practicing, did you have specific strategies? Did you have that kind of thought process going in mind when you were seeing your patients, like, I'm going to kind of address this? Did you do anything in particular for that when you're thinking about stigma as a practicing psychiatrist? Did that grow over your career? Is that something you had to develop, or any insight for the audience here if they're thinking about their own practices here and how they can really affect somebody when they come to see them in the office?
Oh, sure. In terms of growth, yes, I'm a big believer in growing as a clinician. And I remember starting out in those early years being fairly incompetent, not knowing at all what I was doing. So yeah, I think over time, you learn that since stigma plays out differently over the course of the lifetime, that you really not only have to understand the tasks that people are going through at that time in their life, but the fact that, and this is one of the take-home messages, and I became increasingly clear of this over time, but that, words matter. The words that we use to describe what people are going through and to understand their experience matter a lot. For example, those who have lived experience, and I'm a physician living with bipolar disorder, people that have lived experience, their words matter. In other words, putting their words together and sharing their story is really, really important for them. And if we're on the receiving end of people who are sharing their story with us, it's also really important to remember that our words matter as well. How we receive them in terms of embracing them, giving them a sense that they're understood, and having a sense of solidarity. So those are just some of my thoughts.
Yeah, that's great. That's wonderful information, and I think that's a nice take-home point. And I certainly want to touch on some more of that as we go down the road. But before we do that, I wanted to ask you, at the time we're recording this, we're about a little over a year into the COVID situation, the pandemic here, and kind of addressing that since it's current, at least at this time. I wanted to see, I know you let us know you've been retired for about a year or so, but you also have your finger on the pulse on what's going on out there. You with DBSA, as you mentioned, you do a lot of speaking. So I wanted to see what your thoughts were and how the current climate and the current COVID pandemic, if that's affected anything as it relates to stigma in terms of the mental health, again, across various ages. And then you mentioned lived experience. Is that a little bit, have you noticed anything that might have changed with that as well?
Sure. I mean, COVID has been a huge issue, of course, in terms of it being a pandemic, but we also have a mental health epidemic, because of COVID. And the way that I think about COVID, is this way. We can envision like having a stigma meter, that we have our our hand on, and sometimes we can dial it up and sometimes we can dial it down. But given COVID and the stressors, what we have done is dial the stigma meter up overall in our society. And we've done that because COVID is like the perfect storm. It is new. There's much that we don't understand about it. It is scary. And as we know, unfortunately, it is deadly. And we don't really do well with things that we don't understand or that we don't know. So we end up, for example, blaming those who we feel may have brought the virus to us. And we've seen some really xenophobic, anti-Asian attitudes, coming into play. People with lived experience, though, are more likely to get COVID, and they're more likely to die from COVID. And many people don't really understand this. So if, for example, we can look, across the lifespan, if you think of those who have schizophrenia, for example, they are 3 times more likely to die from COVID than those who don't have schizophrenia. And those with bipolar disorder are 5 times as likely to become infected with COVID. And if we think about stigma across the lifespan, it's really, really unfortunate because let's think for a moment about how the vaccine has been rolled out. Now, it has been correct that people with pre-existing medical conditions have been prioritized in terms of getting a vaccine. But those with pre-existing psychiatric conditions, even though they're at higher risk, have not been prioritized. So just think about that in terms of stigmatizing attitudes and how important we have really missed the ball, in that way. Those with mental health conditions have problematic access to health care. They sometimes live in overcrowded conditions. They have difficulty following safety protocols. And there's increasing evidence that those who have serious and persistent mental illness like schizophrenia or schizoaffective disorder or bipolar disorder and certain kinds of depression, that there's an immunosuppressive underlying disease pathology. And so that as well contributes to why they may be more likely to become infected. So things have changed dramatically due to COVID, and let us hope as we vaccinate more and more people that things will settle down from a medical point of view. But I am concerned that we're going to have to be dealing with mental health issues, sequela from COVID, for quite some time.
Sure, absolutely. I think you made a great point there, really pulling out, the mental health lack of response, for lack of a better term. And, it's an unfortunate situation, but hopefully a learning situation when we're talking about it in a forum like this and other places to learn down the road to really make sure that folks with lived experience are getting the treatment they need. Well, thanks for saying that. I thought that was a great point. I want to shift the talk a little bit now and talk about you. You have been open and honest and have disclosed with us earlier, even in this particular chat, about your own experience. That's so important. That's so valuable. You've done all sorts of speaking, working with advocacy organizations to share your story, to hopefully give people a voice to hear if they don't feel confident in disclosing themselves, or maybe not letting a disease or a diagnosis take over who they are. And so you've done a lot of work with DBSA, you've done a documentary about that. And I'm sure when you're talking about that, you're getting some successful response and some challenging response. So can you fill in the audience a little bit, maybe when you're a clinician as well, and certainly what you're doing now, some of those successes and challenges when you tell your story?
Sure. Well, to start things off, yes, I've had bipolar disorder since I've been in college, although I kept it secret like a lot of people, and I must say perhaps like a lot of healthcare professionals. I believed that as a doctor, and maybe particularly as a psychiatrist, I quote unquote shouldn't have any mental health condition, but I do. And so I was concerned about the repercussions, both personal and professional, if I were to step forward and share, my diagnosis with my family and my friends and my colleagues. So what I thought, though, is that despite my concerns about the repercussions, that there was a greater good in doing so, because too many people in my profession and frankly around the world, irrespective of professions, they have no voice. And so I remember back a couple of years ago at the International Society of Bipolar Disorders, I got up in front of an audience and I said, hey, my name is John Budin and I am a psychiatrist and I have a practice in New York City. And guess what? I'm also a psychiatric patient because I have bipolar disorder. And it was one of those moments where, you take a deep breath and you just kind of leap and you hope. But in terms of successes, what happened was really startling to me because I didn't know how that was going to be received, speaking to a large audience, And as it turned out, I received more hugs and more affirmation than I could have ever imagined receiving. And so I was really, really surprised. Now, that doesn't mean that it all was positive. In terms of some challenging experiences, not just with colleagues, but with a patient or two of mine, and we can speak, a little bit more about how my patients have reacted. But, I had a colleague come up to me and say that I should not have been practicing anymore, that having bipolar disorder essentially disbarred me, in his opinion, from, treating clinicians. And he happened to be a psychiatrist. So in some ways, he was like the most knowledgeable person about psychiatric disorders. That's how we psychiatrists are supposed to be. And yet his misinformation and his stigmatizing attitude really struck me. Now, I do think that increasingly over time, his view is in the minority, but I do think as well that we have a lot of work to do to lessen stigma so that those within a range of professions and different experiences in our lives, we have a lot of work to do before those who have lived experiences can speak more freely and step forward without the fear of being shamed or stigmatized. Again, overall, the response I got was really quite positive.
Yeah, well, I appreciate you sharing both the successes and the negatives with it, because I think that really opens some thought. And, you just gave us just a small snippet of that there, but, I could certainly feel impacted by just that story itself. So hopefully the audience will grab that here, and we would love to expand upon that. And you used a word earlier in the talk today about growth. And I think everybody has the opportunity to reevaluate how they look at things, and hopefully we'll get to a point down the road where it's not as big as an obstacle. So thank you for sharing that. That's really courageous. And that's why we're so happy to have you, on board with us here. But you did mention also on your last statement about maybe how patients, when you were practicing, may have responded once they found out that you indeed were diagnosed with bipolar disorder. So would you mind talking a little bit about that and maybe some of the responses you received from that?
Sure. When I got to the point of wanting to make my diagnosis known, the greatest concern I had was not really how family and friends were going to react, and it wasn't really even how colleagues were going to react, because I was prepared regardless for what those reactions were going to be. But my greatest concern was how my patients were going to react. We doctors live by the Hippocratic Oath, which is, first do no harm. And so I wondered, well, whether this was going to be harmful, for my patients. It's easy to find out a lot about me or anyone else these days just by Googling. And so if you Google my name, as patients are wont to do, the first thing that comes up is psychiatrist with bipolar disorder presented at this conference and sits on the board of directors of DBSA. And so it's pretty easy to find out, that I have bipolar disorder. And so I received a number of reactions from patients because they came to know my diagnosis while I was still practicing. So there was a group of patients who frankly didn't care. It just didn't matter to them one way or another. They thought, and they explained to me that as long as I was delivering good care to them and they felt that they were well cared for, it really didn't matter to them at all. Now, there was a second group who probably felt and conveyed it to me that I had perhaps a greater degree of empathy and understanding for them. Having had a lived experience, I could relate more to the fact of what it was like when they had a hand tremor or gained weight from, whatever other antipsychotic we both happened to be on, at that point. But I must say, there was a very small percentage of patients who were quite upset. They were angry with me, and they believed that I should have told them up front that I had bipolar disorder. Their argument to me, and I must say, it was a reasonable argument from where they were coming from where they were sitting and how they saw things. Their argument to me was that I should have let them know so that they were fully informed, and then being fully informed, they could make an informed decision about whether they wanted to see me as a doctor or not. It's, I think, fair to say that not everyone wants a doctor who has a psychiatric disorder, and I don't judge, people for that. It is okay if people chart that course. The only thing I would say is that for people that make that decision, I hope that that comes from a place of knowledge and awareness of how psychiatric disorders can play out or not, being a treating clinician, and not from a place of misinformation or stigma. That's all I would ask. But again, it's legit if people feel, I think, that they don't want to have a doctor who has a psychiatric disorder. So those are the range of experience of reactions that I got.
No, yeah, that's really, really interesting. And I'm going to tie one more in here on you. This will be our kind of last question for the day. But in terms of across the lifespan, when you talk about that, so when you're seeing patients, when you were deciding to let them know, and whatever was your situation at the time, did you have different strategies maybe for younger folks versus folks who are adult or older adults, or were you kind of using kind of a steadfast approach on how you're doing this, or just did it vary on the patient's personality? Or can you speak to that just a second?
Yeah, sure. I think it did depend upon the age of the patient, and more importantly, not just the age, but again, the developmental milestones and the tasks that they were going through. So for example, let me give you two examples. I saw a young person, an adolescent, who came to see me, and he had a history of depression. And he came to see me because he was really destabilized and sort of crushed because the girl he had asked out to the prom had turned him down. Now, this may not sound like a cataclysmic event to us at our age, but trust me, if you think back, that was a very, very big deal. So what we talked about really is that, we have this saying in mental health that growth happens when we lean into discomfort. And growth is a journey. So whether you're taking, and this is what I explained to him, whether you're taking your first antidepressant or whether you're asking your first girlfriend out to the prom, you're entering a new space, and that new space requires us to be vulnerable and to be open. We can't have it both ways. What we do is we either live behind these thick, impregnable walls, trying to be very invulnerable in our lives, or what we do is we step out into this vulnerable world and we take our chances. And that is where true intimacy and connection lies. So when I explained this to him as a young person, I think he really understood that, just as one example, being vulnerable and opening yourself up and being human in that very way was a strength of his, not something that he needed to feel so badly about. So now that's an experience asking out to the prom that a young person would have, not someone who is older would have, but that's just an example of a younger person's experience. And in terms of an older person's experience, I had an elderly woman who came to me, and she had bipolar disorder. And what was amazing is that she had lived with bipolar disorder pretty much her whole life. She had bipolar 2, so she could pretty much navigate her way through without psychiatric hospitalizations. And she started to share her story with me. And when she did, I found it was really remarkably like mine. Years of avoiding treatment, concerns about repercussions if people found out. And what I responded to her with was that I felt like it was really a privilege to be invited into her inner world. And rather than seeing her as diseased and pathological, I really saw her as being just vulnerable, and scared. And so I thought to myself, since I've learned so many lessons in life from the patients that I've had, I thought to myself, well, if I can have compassion for her, I can probably have compassion for myself as well. So it's one of the greatest lessons that I've learned in terms of coming to terms with who I am as a physician living with bipolar disorder, is that it's important to treat ourselves well and to have compassion and to treat ourselves with decency and kindness and generosity.
Wow. That's great. I mean, I think this is just a little snippet of why we could talk for hours and hours on this. I think you've tied all this together very, very nicely for our audience, and hopefully giving some food for thought for what we can do in terms of stigma and mental health across the lifespan, lived experience, how we can incorporate that into just better overall care and treatment. So unfortunately, we're out of time today, but we certainly do look forward to working with you again, Dr. Budin, in the future and hearing more about your story. I would suggest, we mentioned earlier that Dr. Budin does have a documentary, a really nice documentary that was produced by the DBSA, the Depression and Bipolar Support Alliance. And again, discussing his own personal journey, his own personal story, and his willingness and openness to do that, I think is just so impactful and powerful for folks. So we would suggest or ask that all folks attending this today, please check it out at the dbsaalliance.org if you'd like more information, if you'd like to view the video. So with that is going to end our talk today. Again, we'd like to thank Dr. Budin for joining us. We'd like to remind our PsychU members that PsychU is now available as an app on your mobile device. So please download PsychU to access all resources in one spot. And you can keep up to speed on the go with all things PsychU by following our Twitter or LinkedIn or subscribing to our YouTube or podcast channels. And we have multiple conversations around stigma and other topics on the site with future PsychU webinars. So please stay in tune with all that we have doing. And once again, we'd like to thank you for joining us today for our mental health across the lifespan interview with Dr. John Budin, and we hope you all have a great day.
Thank you very much.